If we could have the panelists up for the last session of the day. We went a little bit over, so I'm sorry about that. But it was a good discussion, so I think it was important. I'm David Cohen from the Cardiovascular Research Foundation and St. Francis Hospital in New York. My co-moderator is Professor Sievert from Germany, and we have a very lively discussion panel, and we have some more discussions about the future of TAVR. And the first lecture is entitled TAVR Techniques in Bicuspid Anatomy, Valve Selection, Sizing, and Positioning, which will be given by Dr. Ahn from ASAN Medical Center.
Thank you, Chairman. I am Jung-Min Ahn from ASAN Medical Centers. I'd like to talk the TAVR techniques in bicuspid valve, using the SAPIEN valve. So, where is Alan? Actually, the first event TAVR was done in bicuspid valve around 20 years ago. So, however, in the TAVR trial, bicuspid valve was excluded. But nowadays, we have several registry data show that the SAPIEN 3, Evolut R, both are. There is no significant difference regarding the mortality or stroke rate compared with the tricuspid aortic valve TAVR up to 1 year. Which device would be better? So there is limited data, self-expandable first by balloon expandable in bicuspid aortic valve. Previous bicuspid TAVR registry showed that SAPIEN XT and core valve at 2-year follow-up, no significant difference regarding mortality. More recent BT registry show that SAPIEN 3 Evolut R, no difference in the mortality. However, as we can expect that the complication is different. The SAPIEN 3 is associated with the higher rate of annulus rupture. The Evolut R is associated with the higher risk of moderate to severe paravalvular leakage. How to decide the device sizing? I think this is very important. The Barbadi registry showed that even though bicuspid aortic valve, 90% of patients, the annulus is the smallest portion. The 10%, the above the annulus is the smallest portion. So I think that based on the previous registry, this is my idea. SAPIEN 3, usually I do the annulus sizing. I don't consider the above the annula, just don't do oversizing. The supraannular sizing may be applied to the self-expandable valve, but we need to still establish how to decide the appropriate valve sizing. The bicuspid aortic valve balloon angioplasty was performed more frequently than the tricuspid aortic valve disease. So I'd like to introduce our experience. The last several years, we treated the bicuspid aortic valve ADS3 by SAPIEN 3. That is a proportion of age, younger age, higher rate of bicuspid aortic valve. Bicuspid is almost 12% in all our SAPIEN 3 registry. Most type is type 1 bicuspid aortic valve. Yes, the flare type, tubular type is around 92%. This is baseline characteristic. Bicuspid is younger, so less comorbidity. CT characteristics show that the bicuspid is larger than tricuspid AS. The perimeter is larger, coronary height is higher. The calcification is very important. In previous studies show that the amount of calcification is associated with the long-term mortality because the higher rate of root injury and higher rate of paravalvular leakage. We can classify that even bicuspid aortic valve, less severe calcification, I think the low risk, but very severe asymmetric calcification, LAVEC calcification, LVOT calcification can be considered as the high procedural risk bicuspid aortic valve morphology. We measured the valve calcification volume. Bicuspid aortic valve calcium volume is 600, 2 times higher than tricuspid aortic valve disease. So this is roughly our sizing algorithm was SAPIEN 3 for bicuspid aortic valve. We didn't do much oversizing, just a nominal sizing usually. To compare the tricuspid aortic valve, bicuspid aortic valve TAVR, oversizing is around 5%. Tricuspid aortic valve oversizing is around 10%. According to the calcification volume, severe calcification, we didn't do oversizing. to treat for SAPIEN 3, for selected SAPIEN 3, only 100%. Moderate amount of calcium, 100, but the less severe calcification, even in bicuspid aortic valve, then we apply the similar sizing selection algorithm with the tricuspid aortic valve. Anyway, the overall sizing is smaller in bicuspid. Oversizing percentage is smaller in bicuspid aortic valve. So I'd like to share the several cases. 79 bicuspid aortic valve, annulus area is 589, type 0 bicuspid, asymmetric calcification. So we selected 29 and 2% minus 3 cc underfilling made 28, 2% oversizing. So final aortogram looks fine. So 79, 500 annulus. So very severe aortic valve calcification, 1,300. So we 2 cc underfilling, finally 4% undersizing, not oversizing, 4% undersizing. Final aortogram show that the acceptable range of paravalvular leakage. So 83, the type 1 LAPVE, 710 large annulus, very large annulus. Calcification is moderate, 800. So 9% undersizing, 91. So 29 SAPIEN 3. So final angiogram show that the acceptable range of the PVL. So the every bicuspid aortic valve, so undersizing or nominal sizing is effective and safe for. So I think don't do oversizing in SAPIEN 3. This is procedural outcomes. Pre-balloon valvuloplasty more frequently in bicuspid aortic valve. Post-deal, 60%. No aortic root injury. Pacemaker implantation, 4.5. Significant PVL is 4.5. There's a stroke rate is no significant difference between tricuspid and bicuspid aortic valve. This is my summary slide. When you actually, we need more experience. Case selection is important. Incidence of PVL is increased compared with the tricuspid aortic valve cohort undergoing TAVR. Aortic injury should be cautious. TAVR for bicuspid AS is not associated with the excess risk of mortality and stroke. SAPIEN 3 implantation on bicuspid aortic valve is not generally different from the SAPIEN 3 implantation on tricuspid aortic valve. However, don't do oversizing. Undersizing is safe and effective in bicuspid aortic valve disease. Thank you for your attention.
Thank you very much. I think we have to move on because we are running late. So if all speakers shorten their talks to 4 minutes, then we will make it on time. So next speaker is David Cohen. He will talk about optimal indication for cerebral protection for TAVR, insights from the STS-TVR and PROTECTED-TAVR. And the good news here is completely unbiased because he's not using embolic protection at all. As we
No, actually, we use them in 100% of our cases. I just, but I am, so I'm not biased. I use it in 100% of the cases.
So you're biased in the other direction.
These are my disclosures. So I want to cover 3 things, hopefully briefly, and some of this will overlap with Samir's talk earlier. Is TAVR-related stroke a problem? We've heard differing opinions of that. What is the benefit of embolic protection in current practice, and can we select patients appropriately, all of which came up in the last discussion. So is TAVR-related stroke really a problem? Yeah, I think it still is. These are the data from the TVT Registry in the United States showing rates of stroke over the last 7 or 8 years, and basically the 30-day shown here in red and the in-hospital stroke rates are very similar over time. Perhaps there's been a little decline first in 2020, but I don't think we can necessarily attribute that to anything that we're doing other than treating lower risk patients, which is the thing that's increased the most over that time frame. In terms of is stroke a bad thing, it absolutely is. I don't think anybody disagrees with this. This is data from Medicare data Medicare claims, looking at the outcomes of patients who had a stroke versus those who did not. You can see there was about a threefold increase in mortality at 30 days. This got to be a little bit less in 1 year and 5 years, but still statistically significant. There was a significant reduction in the number of days patients spent at home, and it cost the healthcare system at least $9,000 over 1 year of follow-up. So stroke is bad, not a hard thing to convince people of. So what is difficult to convince people of, or where there still is a lot of room for debate, is what the benefit of embolic protection is in current practice. These are the devices that have been tried. Some of them are available in other countries. The only one that's available in the United States, and the only one that has really undergone meaningful testing, is the Sentinel device, which we've been discussing, the radial access device through a 6 French sheath. And prior to the PROTECTED-TAVR trial, this is really the best data that we had on Sentinel, the Sentinel IDE trial, about 360 patients in the United States who were randomized to Sentinel or no Sentinel, and the primary endpoint was a reduction in lesion volume measured by MRI. And you can see here there was a trend towards greater lesion volume in the control group, but it was not anywhere close to statistically significant. Now, interestingly, there was, in a post hoc analysis, a reduction in hospital stroke, which was no longer statistically significant at 30 days, but the trial was definitely not designed to look at stroke. And so as a result of this trial, when Sentinel was approved in the United States, it was approved with this label, which says that it's approved for capturing and removing thrombus and debris. So the FDA was very literal. We can retrieve debris, and that's what it was approved for, but not for reduction in stroke, not for reduction in brain injury by imaging. So with that in mind, the PROTECTED-TAVR was designed to try to answer the question, are we really doing good when we use embolic protection? You heard this, those of you who were here for the previous session, from Samir Kapadia. All patients undergoing commercial TAVR, US and Europe, patients had a neurologic exam pre-procedure, randomized 1-to-1 to TAVR with or without the Sentinel device. Everybody had a neurologic exam post-procedure, and the primary endpoint was stroke at 72 hours or discharge. And here is the primary results. There was no statistically significant difference, not even close, to a reduction in overall stroke. The relative difference here was about a 20% relative reduction, but again, not at all statistically significant. But what was very interesting and intriguing was the signal for disabling stroke, where there was about a 60% relative reduction and a 0.8% absolute reduction in disabling stroke, which was one of 6 pre-specified secondary endpoints. And so they made a very big point in the paper of saying, we cannot, this is hypothesis generating, and Samir actually said that as well. If you look here at the other endpoints, non-disabling stroke, TIA, composites, mortality, acute kidney injury, they were all similar. And so if you put all the data with the Sentinel device together in a meta-analysis that we have from randomized trials with respect to any stroke, there still is not a statistically significant signal here, driven mostly by the PROTECTED-TAVR data. One interesting question is whether we could have predicted the PROTECTED-TAVR data, and Samir mentioned in his presentation that we did an analysis of about 120,000 patients from the TVT Registry, published it 2 years before PROTECTED-TAVR was published, and in that analysis, we found in the primary analysis about a 10% relative risk reduction for stroke, which was not statistically significant, but in a secondary analysis, we found about an 18% relative reduction of stroke. And if you look at the PROTECTED-TAVR results, they are virtually identical to that. And I think one of the challenges with PROTECTED-TAVR is it was powered to detect a 50% reduction in stroke. It's very clear from the data that there's no way that we get a 50% reduction in stroke with the Sentinel device. Now, what about the disabling stroke data? Again, this is really the source of the controversy. I think there is no question that disabling stroke is the endpoint our patients and their families are most concerned about. And I think in light of the previous studies, as well as the mechanisms, the suggestion that embolic protection converts major strokes into minor strokes, which is really what was observed in the PROTECTED-TAVR trial, is mechanistically and biologically plausible, but that's not how we practice medicine. That's not how we approve devices. In the context of this overall neutral trial, we really have to look at this single secondary outcome among 6 that are assessed to be hypothesis generating. And if you look at even at the confidence interval for that benefit, it could be as low as 0.1%, 1 per 1,000. And even Dr. Kapadia, in his paper in the New England Journal of Medicine, said that the 95% confidence intervals for the secondary endpoints should not be used to infer definitive treatment effects, a very fancy way of saying we need more studies. So to me, right now, the one approved device that we have that's available in multiple countries, the Sentinel, it definitely captures debris en route to the brain. 3 out of 3 trials have shown it captures debris. Maybe, based on the trials we have, it reduces CNS lesion volume, but 1 of the 3 trials was positive with respect to this endpoint. But to my opinion, looking at, as objectively as I can at the data, what's unproven still is whether there's a reduction in stroke. And what is absolutely unproven as well is whether there are improved late neurocognitive outcomes. Finally, the issue of selecting patients. So Vinny Bapat mentioned in the last panel that, he knows who's going to have a stroke. I would claim that the data, again, suggests that we don't know who's going to have a stroke. We published a couple of years ago a stroke prediction model from the TVT Registry in 97,000 patients. We found a lot of predictors. There are a lot of things that are associated with stroke, but if we look at the discrimination, our ability to predict stroke, the C statistic here is 0.62. That's barely better than a coin flip. So we have predictors, but we can't, in any meaningful way, identify who really is likely to have a stroke. And this doesn't even count disabling stroke, which is rarer and harder to predict. If you look at the subgroup analyses from the PROTECTED-TAVR trial, again, Samir showed these, they're all very consistent. There is no real particular group that stands out here where there's more or less benefit, except this intriguing, but I think fairly unpredicted benefit that was greater in the US than the outside the United States. I don't think it's explained by the valve types, because you look here and there actually is an analysis by valve type and it didn't differ by valve type. So I think this is more likely to be a fluke than anything true. So I would say the implications here are that the prediction of stroke in TAVR is challenging and prediction of disabling stroke is almost impossible. And so I would submit that based on the data we have, not the emotions, but the data, there's only 2 rational strategies for using cerebral embolic protection. Either use it in everyone or use it in no one. Now, is there any evidence that maybe we can predict? Actually, our study in the TVT Registry did suggest 2 groups where there might be more benefit. But again, these are not statistically significant. But again, I would highlight here that the groups where there seemed to be a benefit in this non-randomized analysis, but used some pretty sophisticated statistical techniques, bicuspid valves and valve-in-valve procedures. So maybe, bicuspid valves are about 5% of who we treat. Valve-in-valve procedures are another about 5% of who we treat. So if we wanted to say, what's the 10% of patients I really might want to favor treating, these would be the 2 groups. So my summary of the data so far is that stroke is a significant and unpredictable complication after TAVR. Embolic protection devices clearly capture procedure-related debris and maybe reduce the volume of new brain lesions. But the clinical benefit, which is what really matters to our patients, is uncertain, and despite increasing use in the United States, and we really need more trials. We have the big UK trial that's going on, and we should have data from that in another year and a half to give us, hopefully, more definitive data. I believe that selective use is really difficult to justify at present, with the possible exception of valve-in-valve TAVR and bicuspid AS. And I think we do need some more studies. We heard some very interesting data from Taiwan this morning about neurocognitive effects, and that could actually tip the balance. If we really knew that the shower of debris that we get in every single TAVR procedure led to long-term neurocognitive consequences, that might, even without a benefit on stroke, change the equation. Thanks very much.
Thank you very much. Next will be Tullio Palmerini. He will talk about coronary protection in patients undergoing TAVI at high risk for coronary occlusion, and maybe at the end we can discuss whether all patients need coronary protection.
Thank you. So there are basically 2 mechanisms for coronary obstruction. The first is leaflet displacement, such that leaflets are displaced toward the coronary ostia in deficient sinuses, and the risk factor for this mechanism is coronary height and sinus of Valsalva depth. Then we have the other mechanism, which is sinus sequestration, which the leaflet seal at the sinus level, and risk factors for this mechanism are STJ height and wideness, leaflet height, and of course coronary height. There is a third mechanism that we should consider for valve-in-valve procedure, which is coaxiality of the bioprosthesis in relation to the capacity of the aortic root, such that if we have a coaxial aligned bioprosthesis in a capacious aortic root, there is no risk of coronary occlusion, whereas whether the bioprosthesis is tilted or is aligned by the aortic root has not enough capacity, you may have coronary obstruction. So there is a practical way to estimate the risk with valve-in-valve procedure. It's the 1-2 technique in which you align two coronary post, as the surgeon doesn't put the post in front of the coronary ostia. It's going to be likely that you have a perpendicular projection when you engage the left coronary artery. Then the leaflet is outside the post, but it won't go outside the sewing ring, and you calculate if you have enough space for coronary perfusion. So let's see this case, 85 years old, a female with 2009 operated with Magna 23. The plan is valve-in-valve with the Sapien Ultra. This is the CT scan. Left coronary artery is definitely low at 5 millimeters. Sinus are not that wide, and VTC is borderline. So in this case, we use the 1-2 technique, and you see that engaging left coronary arteries, there is enough space both at the sinus level and at STJ junction. And therefore, in this case, we decided not to protect. We put the valve, and you see that there was no necessity of protecting the coronary artery, even though coronary 8 was at 5 millimeters. So these are the risk factors for procedural coronary obstruction: height of coronary ostium, SOV dimension, STJ height and dimension, extreme oversizing, the use of certain valves such as mitral flow, trifecta, and stentless, severe aortic valve calcification with the large left calcium nodule, especially in bicuspid aortic valve, and post-dilatation. So there are three methods to protect coronary artery: chimney stenting, basilica, and leaflet splitting. So the chimney stenting has been investigated in these multi-center interventional observational studies involving 19 centers in which we have 3-year follow-up. We collected 236 cases of coronary protection, 143 of whom underwent stent implantation, whereas in 93 patients, protection was performed with one only. So what is this group? So in this group, the operator performed the procedure with a wire in the coronary artery, and at the end of the procedure, he decided not to put the stent because he judged that there was no necessity to put a stent. So these are the results at 3 years, and surprisingly, you can see that mortality with coronary protection just with a wire was almost double than coronary protection with a stent. So let's analyze the outcome stratified patients according to the strategy of protection. Stent protection, we had 2 cases of stent thrombosis, 2 cases of sudden death. Wire protection, we had 2 cases of sudden death, and surprisingly 4 cases of delayed coronary occlusion, which is 4.1% rates. So in these cases, 3 patients out of 4 patients died, and delayed coronary occlusion occurred between 5 minutes and 6 hours. So what did it happen? So probably it's very difficult to establish whether there is enough flow with a guide catheter in the sinus and the wire in the coronary artery, such that this system can push the leaflet down. And then when you remove it, then you can have the leaflet that is displaced toward the coronary ostium. So now let's analyze the outcome according to the type of valve. Self-expanding valve, we had 2 cases of stent thrombosis in valve-in-valve procedure, whereas there were no cases of stent thrombosis with the balloon expandable valve. Multivariable analysis, self-expanding valve were the only predictor of cardiac mortality at 3 years. Basilica technique consists in lacerating the right or left leaflet or both leaflet using an electrified guide wire. The lacerated leaflet is placed after TAVI to allow blood flow across it. So these are the data of the Basilica Registry, 214 patients from 25 centers. So procedural success was 87%, so not that high, with 4.7% partial or complete occlusion. So in these cases, the operator had to put a stent. Mortality at 30 days was 2.8%, and the rate of stroke was 2.8%. But we have to keep in mind that in this registry, protection devices were used in 47% of cases, because in the previous Basilica AIDE registry, stroke rate was 10%. So probably, if you use Basilica, this is one subgroup of patients in which you should strongly consider using protective device. And finally, the shortcut device system. It has an handle, a delivery system, and a distal unit to split the leaflet. The device is advanced through the femoral artery. You have to use a 16 French sheet. It's advanced over a 0.35 inch wire in the ventricular, and then the system is unsheathed and then oriented towards the leaflet that has to be cut. At this point, the leaflet splitting device is activated, the system is pulled back, and this is the way in which laceration occurs. So it was used in a series of patients, 8 patients with 11 leaflet laceration, and the results, even though the population is very small, are really promising, with no coronary obstruction and no adverse neurological events. So in conclusion, iatrogenic coronary obstruction during TAVR is associated with high rates of mortality and morbidity, coronary height, soft dimension, leaflet height, STJ height and wideness, valve-in-valve procedure, post-dilatation, and VTH are risk factor for coronary occlusion. Chimney stenting, Basilica, and shortcut device have been proven to be effective in preventing coronary obstruction. Thank you very much.
Thank you. We will continue moving on, and the next speaker is going to be James Flaherty from Northwestern. He's going to be speaking about ultra-minimalist TAVR, strategies for a quick procedure and a short hospital stay. Thanks, James.
Thank you very much, and I will try to be quick. Nothing to disclose from this. So here's the original partner cohort A data. We can see 30% were transapical, and all the transfemoral by surgical cut down. Fairly high complication rates by today's standards, but not so bad if you think it's first generation. ICU stay 3 days, and median length of stay 8 days. Well, we've come a lot more efficient over the past 10 years. More experience, use of CT, percutaneous access, smaller sheaths, conscious sedation, better planning. The first big breakthroughs were CT. We didn't use CT routinely when TAVR first started, but this lets us know what valve size to use, tells us about our access, coronary heights, angles, deployment. Definitely makes the planning a lot more smooth. And the next one was percutaneous access and closure. This is surgical versus percutaneous. It's quicker, the recovery's faster. And that led to the next breakthrough, which was conscious sedation instead of general anesthesia with TE guidance. And in this study, they showed that over time, more conscious sedation was used, and it started to decrease length of stay, and actually was associated with better outcomes in terms of death and stroke. This is the 3M study. The group out of Vancouver looked to see if they could apply a minimalist strategy to hospitals that did low, intermediate, and high volumes. Basically, they just came up with a protocol, and they said, follow the protocol as best you can, percutaneous access, conscious sedation, planning with family, things like that. You just follow the protocol, and if you just did that, these 2 groups did the same in terms of heart outcomes, mortality and stroke, and achieving next day discharge, and like 80% in all 3 groups. So if you follow protocol pretty strictly, everyone does the same thing, you can do it quick and do it safely. This is single-site access. This is a study out of Cleveland Clinic. They took 1,200 patients, and they looked at unilateral access in about a fifth of them. There was no difference in vascular complications. As they got better at it, vascular complications went down. And if there was a problem, the way you do this is you put your pigtail sheath and 5 French below your TAVR sheath on the same side. If you have a narrowing, you don't have to cross up and over, which takes 20 minutes. You just go in with a balloon and you dilate it and you're done in 2 minutes. This also facilitates getting all the sheaths out before the patient leaves the room because they're all on the same side, including the pacemaker. Some places are doing LV pacing instead of putting a transvenous pacer. You just hook up an electrode and an anode and pace from the LV wire. This doesn't work for all wires, but it does prevent the need for venous access in most cases. And it's safe and effective. And this is another study out of Cleveland looking at pacing the right atrium after TAVR deployment. Basically what you do is you pull your pacemaker back, you put it in the right atrium, and you do stepwise pacing, 70, 80, up to 120, and you look to see if you induce Wenckebach. And if you don't induce Wenckebach, even if you have a left bundle, pacemaker rates are 1%. So that tells you that there's a very good chance that this patient is ready for discharge either the same day or the next day without the need for a pacemaker. What about monitoring? We call it MCOT or mobile telemetry. About 15% of patients will have significant conduction or AFib part of the procedure if you monitor them, and about 10% will have conduction delay post-discharge. So if you're really worried about someone who's going to develop heart block, they've got incomplete trifascicular block, maybe they're getting lightheaded, put the monitor on a couple weeks before, and maybe you'll find out that they need a pacemaker regardless of the TAVR and take it out of the equation. Or if you're worried about sending them home early, you want to make sure you catch anything, you put a monitor on after. What about same-day discharge? Well, the COVID era led to more enthusiasm for this because nobody wanted to be in the hospital. And so in this PROTECT-TAVR trial, they took about 2,000 patients. They looked very strict criteria. They got to 6% of them that they thought would be good for same-day discharge. Here they are. They're 78 years old, low STS scores. About a third had pacemakers already. And of all this, only one of them got a pacemaker and went home the same day anyway. And the 30-day, very broad outcome for events was about 5.5%, which is consistent with those that stayed longer. We developed our own protocol based on this and other data, and institutions can do this. Just come up with criteria where you think it's safe, and you can probably find maybe a quarter or so your patients can be safely discharged the same day. So best practices for a quick procedure and a quick discharge. Pre-procedure, consider a monitor. If you think they're high risk of heart block after TAVR, percutaneous access and closure whenever you can. Use your CT to look at your coronaries. You don't have to do angiography in everybody anymore. Do all your discharge planning up front. Get expectations with family set so there's no surprises when you want to send them home on day 0, day 1. And come up with criteria that work in your institution for potential same-day discharge and follow them. In the procedure, conscious sedation, or some would go MAC with an anesthesiologist. Avoid extra lines like radial art lines and things that really don't add to the procedure. Someone said this before, predilation is really not recommended on a routine basis. In some cases you might like BAV, but you don't have to do it obligate. Aortography can be used instead of doing a full echo in the lab or in the OR to see if there's any paravalvular leak. For pacing, you can consider LV pacing. You can use the existing pacemaker they have. You can do stepwise RA patient if you want to check out their risk of heart block after. And remove all the sheaths before they leave the room. This is really important to get them early ambulated. Get those sheaths out whenever you can. Post-procedure, if they have complete heart block that you don't think there's recovery, just put the pacemaker in the same day. Patients rarely should go to the ICU anymore. They should go to a tele or a step-down bed. Ambulate as early as possible. If you want to do an echo, do it the same day. Once they're awake and conscious and have normal blood pressure, you can get that out of the way. And consider an MCOT monitor if you're worried about conduction and don't want to have them stay just for that worry. So finally, you'll talk about the little study we did looking at when patients after TAVR, when they get a pacemaker, do they use it? And in this study that we did, looking at 600 patients, only about 20% were using their pacemaker at 1 year. And among those that used it, those are the ones that had complete heart block or some kind of extended heart block. The other indications like new left bundle with first degree AV block or other things, they really stopped using their pacemaker. So it lends to the notion that maybe we're putting in too many pacemakers post-TAVR. So what can solve that? Well, there's development for bioresorbable pacemakers. This has been worked on for post-surgery, not having to put wires in, but there is thought of doing a similar concept post-TAVR if you're really worried about the patients at high risk but don't quite meet an indication for pacemaker, maybe there'll be a device in the future that can bioabsorb and not have to keep them in the hospital while waiting to see what happens. So in conclusion, TAVR, especially from the transfemoral route, has become a routine outpatient procedure for most patients. Pre-TAVR planning and interprocedural techniques have improved safety and dramatically reduced procedural times. Next-day discharge is now very common, and in select patients, same-day discharge can be considered. Practice standardization via institutional protocol helps facilitate minimalist TAVR and early discharge. Thank you.
Thanks very much, James. Next, another interesting discussion of a problem we were only recently starting to understand. Dr. Alok Finn from the CV Path Institute is going to be talking about HALT.
Great, thanks a lot, David. Thanks for the organizers for inviting me. It's really great to be back here. These are my disclosures. So as a background, thrombus morphology evolves over time from a loose mesh of fibrin and platelets to a compact structure of acellular cellular components, which we call organizing thrombus, with eventual infiltration by muscle cells and collagen, which we call organized, that are essentially is resistant to any anticoagulation treatment. This is the natural history of any type of thrombus in the body. The gold standard for the diagnosis of subclinical leaflet thrombosis after surgical or TAVR is a CT scan. The characteristic findings on CT is hypoattenuating opacity at the base of the valve leaflets or hypoattenuating leaflet thickening called HALT, which you're all familiar with. So HALT identified on functional cardiac CT can affect valve function, as we all recognize, and clinical outcomes. And it's probably important, though it remains controversial, whether identifying HALT may be important for improving long-term outcomes after TAVR. High-resolution imaging such as micro-CT, which is really a high-resolution CT not available in the clinic, may yield further insights into the pathophysiology of HALT and is likely to be able to distinguish different stages of HALT. And I should also mention, HALT really hasn't previously been histologically confirmed, so this is part of the details of the study. So for the first time, we're really looking at the micro-CT changes of HALT with histologic changes of valve thrombosis and characterization over time. So the aims of the study were to really evaluate the extent of pathologic changes of valve thrombosis, needle thickening, inflammation, calcification, and leaflets over time in TAVRs, explained as surgery or autopsy, and to compare the micro-CT findings of HALT with the histologic findings of acute organizing or organized thrombus to really see whether micro-CT could better define what HALT is doing in an experimental aim. Study design, we used 123 explanted or self-expanding tabs. Tabs were used, assessed from a population of 7,500 participants from 11 clinical trials across surgical risk groups. This was done in collaboration with Medtronic. These are Medtronic valves. Explanted valves represent less than 2% of all patients. Clinical thrombosis rates were very low, 0 to 1.3% in these trials. And the valves were explanted due to surgery or autopsy, majority autopsy, I should say. So 123 TAVRs, we excluded infective endocarditis. You can see analysis population was 110. And the time points of the collection of those valves were different, evenly spread between less than 30 to 365, and greater than 365. And we use different methods histologically to classify the leaflets and do the scoring for the different endpoints. I'm not going to go over all the details here with you, but we were basically looking at thrombus and new animal calcification, inflammation, and structural changes, and scoring each of these in terms of a scoring that I've shown here, and I'm happy to talk to you about it after this talk. Micro-CT HALT histological leaflet thickening grading. Of the 110 tabs, micro-CT imaging was performed in 40 cases. 4 cases were excluded because of intrinsic calcification or image quality. 36 cases were available for micro-CT. And it was really defined as HALT was defined as an increase in leaflet thickness greater than normal and graded based on the length of leaflet involvement, somewhat similar to what's done in CT. And you can see here the grading that was done according to the amount of HALT on the leaflets. So the case characteristics, 110 cases overall, you can see they're evenly split among the, basically among the time points that they were collected, the duration of implant in terms of days is given there in the yellow. STS prom scores tend to differ, but otherwise everything else was fairly similar in terms of the cases that were collected over these different time points. And so this is the results of histological semi-quantitative scores by implant duration. You can see that what we found, the salient findings are there was really no change in thrombus and inflammation scores over time according to the time points collected. Needle thickness was increased over time in the leaflets. Still, needle thickness greater than 365 days was pretty low grade 1. Structural changes were also increased over time as valves aged. You can see they were slightly higher, but still not nearly requiring any kind of intervention. And calcification scores also increased with greater implant duration. So the evaluation of leaflet thickening, histological leaflet was evaluated in 320 leaflets, 110 cases, as I mentioned, and it was micro-CT was analyzed in 106 leaflets from 36 cases. And here I'm just comparing the histology group and the micro-CT group, just to let you know that they weren't extremely different. There were some differences in the duration, the reason for explant. You can see autopsy cases predominated in the histology group, and AV reintervention was greater in the micro-CT group, and there were some other differences as well. But you can see that approximately 45% of leaflets showed at least some degree of leaflet thickening. The prevalence of leaflet thickening was comparable between micro-CT and histology. So very good for evaluating leaflet thickening. And you can see histologic halt occurred from acute organizing and organized thrombus. And you can see here we had acute thrombus in 35 leaflets, organized in 93, and organized in 21. The type of stage of thrombus organization really could not be differentiated by micro-CT. And what was important to know is leaflet thickening was absorbed more frequently, as you would expect in implants of longer duration. All thrombi less than 30 days were considered acute, while most organizing thrombi occurred in valves greater than 30 days. And you can see thrombi were almost exclusively organized after 1 year. And you can see here in terms of the organizing, and acute thrombus, there were certainly very big differences in the amount of time that had passed. So limitations was a pathologic analysis of a small subset of self-expanding valves implanted from 11 clinical trials. Valves implanted autopsy could be obtained from patients with cardiovascular and non-cardiovascular death and may not be representative of populations with valve failure, those that go on to survive. Pathologic findings are not linked to clinical outcomes, and cases cannot be compared to living patients. So in summary, this was the first study to compare micro-CT and histologic findings of leaflet thickening. It occurred in 45%. Clinical thrombosis rates are extremely low in clinical trials of self-expanding TAVRs, as I mentioned before. There was no relationship between the duration of implant and thrombus and inflammation scores, although neonatal thickening, structural changes, calcification scores increased with time and were most pronounced after 1 year. Histologic examination confirmed 3 types of thrombi, as I mentioned, acute, organizing, and organized, which could not be differentiated by micro-CT. And the implants greater than 30 days really showed findings consistent with organization, while the majority of those greater than 1 year were either organized or really organizing, mostly organized. These findings may explain why oral anticoagulant therapy is not always effective and suggest that identification of HALT and response treatment may be most effective within the first year after implantation, especially in younger patients. So with that, thank you.
Thanks very much. So we have one more talk, which is Dr. Do-Yoon Kang from ASAN Medical Center going to be speaking about up-to-date TAVR data from the ASAN Medical Center.
Yes, I will talk as brief as possible. I will just introduce the recent data from ASAN Medical Center. We made the TP-TAVR registry with our center, and Northwestern with the James Ferrari and Wen-Lieng from Stanford registry. And we compared 3 hospital data with the Asian and versus non-Asian, the characteristics of the TAVR. The Asian patient has the smaller BMI, and the risk profile was better. And the clinical outcome, as you can see, the unadjusted, the outcome was better in Asian population. However, after adjustment, the clinical outcome was similar. So the clinical characteristic difference was shown, especially with the smaller body area and the lesser clinical characteristics with the high risk. However, the clinical outcome was similar after adjusting the baseline characteristics. And the second paper was the JAG intervention about the patient prosthetic mismatch after TAVR. And also compared Asian and non-Asian patient. And because the PPM was defined as the indexed EOA, and because the Asian population has the smaller BSA, the PPM rate was lower. However, the clinical outcome was not different between Asian and non-Asian, and PPM and no PPM patients. And we are preparing the second wave of the TP-TAVR registry, including the patients from the China and expanding more patients. And second is ADAPT-TAVR trial that was published last year. The random trial that compared 220 patients without OAC indication after TAVR to the edoxaban versus dual antiplatelet therapy. And the primary endpoint was the cardiac CT, heart finding, and the enrollment was done in South Korea, Hong Kong, and Taiwan. So the endpoint, this is primary endpoint, valvular reflex thrombosis tended to be lower but not statistically significant in edoxaban group. In PP population, there was some difference. The reflex motion grade though was a little bit better in the edoxaban patient, but not different because of the smaller patient number. However, the MRI endpoint with the new cerebral lesion, new lesion numbers, and new volume, the volume of the new lesions was not different between the edoxaban and dual antiplatelet therapy. And also the neurological or neurocognitive endpoint was not different to drug, and also the correlation analysis between the reflex thrombosis and the brain imaging was not significant. So we concluded that the use of the edoxaban decreased the heart a little bit, but it was not related to the neurocognitive event or MRI findings. However, this is a short-term follow-up study of the 6 months, so the impact of heart on the valve durability is further need to further investigation. And another is ASAN TAVR registry with a single center prospective registry that we tried to find the risk factors that shows the impact on clinical outcome after TAVR. One was the calcium. High amount of calcium showed higher procedure worse outcomes, but 1 year clinical outcome was not different between the calcium groups. Second was the left ventricular global longitudinal strain in TAVR patient. The patient with the impaired global longitudinal strain showed a worse clinical outcome even in patients with a preserved LV ejection fraction, and adding the value to the clinical and LV ejection fraction showed better the discrimination of the clinical outcome. Another is the different ECG LVH criteria. The Cornell criteria only showed the impact of the cardiovascular death and all-cause death compared to other criteria. And impact of sarcopenia in patients with sarcopenia showed worse clinical outcome, and the patient with the patient with the STS score high or lower, the sarcopenia showed impact the worst clinical outcome. And another is the impact of the immediate improvement of the 5% or more LV ejection fraction. The patients showed the increase in LV ejection fraction immediately after TAVR showed better clinical outcome in 3-year follow-up. The last is the ASAN AVR registry that we gathered all patients in our center with a surgical AVR and transcatheter AVR, and now we are making the more firm database. And our surgeon, Ho-Jin Kim, published the paper for sutureless AVR, rapid deployment AVR, compared to TAVR and conventional TAVR, and they showed similar clinical outcome. The last is the severe aortic stenosis with the low valvular calcification that is under review, that the patient with underwent surgical or transcatheter AVR that had the lower valve calcification had a higher the incidence of the death even after the AVR procedure. The cause mechanism is not very definite, but it's a very hypothesis generating the research. Thank you for your attention, and details will be presented tomorrow morning in all about new data session. Thank you.
Thank you very much. I think in the interest of time, we are over time already, and we should call the session to an end. Wish everybody a good evening, and we'll see you tomorrow for another set of very interesting sessions. I want to thank all the presenters and apologize to the panelists who didn't get a word in edgewise. I apologize for that.